to discuss their non-opioid analgesics and non-steroidal anti-inflammatory drugs. Well, before I start my session, I would like to ask you, what about pain, and does it actually familiar to you that pain is a negative psycho-emotional feeling which can be realized by pain sensitivity system, yeah, in the upper areas of our central nervous system. You understand that pain, it's a kind of a safety reaction of our body to some signals. It just gives us some signals about the danger in our body, and it may help us to identify the problem. As you can see, that it's a universal response of the organism to damage, to inflammation, to ischemia, for example, to hunger or some other pathological processes. And on the one hand, it is a protective mechanism. On the other hand, it's a signal of non-well-being, and we have to deal with it. And we understand that, for example, if we start the treatment of any kind of pathology, still we must not feel any pain. Because pain causes discomfort, it decreases the quality of life, and it may cause a pain shock. Yeah? So we must not tolerate pain, because otherwise it may damage our central nervous system perception. What is the physiological role of the pain sensation? I would like you to remember and to note a new term which is called nociceptors. Yeah, it is produced from the Latin word nocere, which means damage. So pain mediators, which are called ergogens, because ergo in Latin it means pain, and these pain mediators or ergogens that affect nociceptors, these painful receptors. It could be catecholamines, and right now you know epinephrine and norepinephrine, and you know the real difference between these adrenomimetics and dopamine, acetylcholine, substance P, bradykinin, and a lot of histamine and serotonin may be considered as pain mediators. And also some prostaglandins, they increase in nociceptor sensitivity to chemical and also to the thermal stimulus. While we have this rather complicated system of pain formation, we also should remember about impulses, because they can be caused by painful stimuli, and they spread along the fibers and enter their special areas of our central nervous system. While they are transmitting to the higher central nervous system centers, such as thalamus, reticular formation, hypothalamus, and cerebral cortex. Here you can see the structure of it and the algorithm of the pain formation, which starts from nociceptors, from the afferent fibers, and goes to different ways, to the specific or non-specific one. And finally, we can feel the pain, and sometimes it takes emotional and psychological assessment. There are different types of opioid receptors, like kappa, like sigma, like delta, like epsilon, like mu. And for example, if we speak about mu receptors, you can see that they provide a wide range of the pharmacological activity, such as analgesia, sedation, euphoria, physical and psychological dependence, bradycardia, and anything else. And before we start the description of the drugs, I would like to ask you, have you ever felt any pain? Or maybe you have just a situation that you are the person who is possible to feel not to feel any pain at all, and whether it is possible to be tolerant to any pain. Just a small, I may say, joke to you from their very famous movie, The World Is Not Enough, Agent 00007. You remember that there was an spy here, who actually had the bullet in his brain, and this bullet has destroyed his senses and made him tolerant to any kind of pain, even though he was felt alive. Yeah. So you should remember that really our pain is concentrated in our central nervous system, and that is why the painkillers or pain correctors, they act on the different levels of the pain formation. If we speak about general anesthetics, and you remember we spoke about the efferent system, and the drugs that affect the efferent system, and it were local anesthetics. But if we apply anesthetics generally, they also will reduce the activity of the central nervous system, and it may cause the different pharmacodynamic effects, which start from the first and the last stages of narcosis, which we really need during any surgical operation. And as an indication, they're going to be the general anesthesia. Yeah. If we speak about opioid analgetics, they act on the central nervous system, but their mechanism of action goes through opioid receptors. We have just spoken about them, like mu receptors. And the indication when we apply opioid analgetics are the cases of severe pain, and also they have an ability to inhibit cough, to inhibit breathing systems, and to inhibit emetic centers. That's why when we, for example, take the drugs that contain codeine, yeah, and when we take the syrups against cough containing codeine, we should be very careful, because along with anti-cough activity, these drugs may also cause the decrease in breathing. The indications for opioid analgetics are the cases of only acute and severe pain, which is not tolerated and which is not which does not respond to any other painkillers. And actually we consider this kind of pain as a very dangerous and life-threatening state. Also, we should speak about non-narcotic opioid analgetics, which can possess their pharmacological activity with the help of the inhibition of cyclooxygenase enzyme, and as a result, they inhibit the formation of the prostaglandins, PG, you can see them on slide here, and finally it brings the patient to the control of the mild pain. Along with it, we may observe antipyretic activity. It means that these drugs can decrease the body temperature, and anti-inflammatory as well. We may apply not narcotic analgetics in case of the non-dangerous pain and in case of fever and inflammatory diseases. We shall start our discussion with the classification of opioid analgetics. They have two big subgroups, as you can see. They are reflected on slide. They belong to the first big group, considering like a natural or semi-synthetic kind of opioid analgetics: morphine, codeine, amnapone, the semi-synthetic drug codeine phosphate, and also ethyl morphine hydrochloride. Along with synthetic and agonists and antagonists of opioid receptors, here you can see among the synthetic agonists there are fentanyl, romidol, tilidine, and all the rest. So fentanyl, and also the antagonists of opioid receptors such as naloxone and naltrexone. What is the history of opioids, and why do we call the whole group as the opioids analgetics? Opium was extracted from poppy seeds, or like the Latin name of this herb is Papaver somniferum, and it is used for thousands of years to produce euphoria, analgesia, sedation, relief from diarrhea, and cough suppression. And why do we call it copium? Because our Greek colleagues, I may say, said that it was the meaning of juice. And as you can see, that opioid is a natural or synthetic drug that binds to opioid receptors, producing agonist effect. You can see that this damage-causing nociceptive stimuli can be in case of mechanical, thermal, and chemical triggers. What are the pharmacological effects of the opioid analgesics? First of all, it is a sedation. Yeah, so it's not only the pain-killing activity. Along with it, we have a wide range of other pharmacological reflections, and the one of them is sedation, which includes drowsiness, apathy, cognitive disorders, and sense of tranquility. Along with it, we may observe inhibition of respiration for all opioid analgesics. Why? Because they decrease the sensitivity of respiratory center to carbon dioxide, and as a result, during the overdosing of the opioid analgesics, a lot of patients, a lot of persons who are abusers of opioid analgesics, they can die due to the opioid overdosing. And the combination of opioids and alcohol is especially dangerous. You may ask me why? Because alcohol induces their opioids bioavailability to the central nervous system. And that is why this overdosing is achieved. Along with the above mentioned effects, so we may observe cough suppression because opioids suppress the cough center in the brains in our central nervous system, which is called medulla oblongata. And also opioids and analgesics, they may cause the constriction of pupils like meiosis, you may see it. Nausea and vomiting, gastrointestinal symptoms, because they can relieve the diarrhea, they have the direct action on the intestines, and other effects which you can see right now on slides. Let's just speak about the main natural or opioid analgesic, which is represented by morphine. As you can see, that morphine inhibits the centers first of pain sensitivity, and it could be good. Yeah, it decreases the coughing center, but sometimes it's not so good because it also, along with the anti-cough activity, decreases the respiratory center. While making the vasomotor inhibition and the center of thermoregulation, we may also observe a lot of side effects while using this drug. Morphine irritates the center of the oculomotor nerve, and that's why it may cause meiosis and may cause bradycardia and some activities from gastrointestinal tract. Let's discuss the pharmacological phase of opioid analgesics. As you can see that morphine here, it may cause a standard analgesia and the duration of action is rather long, 6 hours, yeah? But unfortunately, it decreases respiration. Fentanyl, you can see that this analgesia is 200 times higher than in morphine, while the duration of action is only half an hour. And along with this huge analgesic activity, we can see the significant decrease in respiratory activity, which could be considered as a life-threatening for the patients. You can also compare, for example, other activities of codeine and of morphine, which are given to you in the comparison to the morphine activity. For example, codeine is a very well-known compound that is widely used for the anti-cough drugs, has a less analgesia than morphine, but the longer duration of action. And what is so good about codeine and why it is actually used for their drugs against cough because it doesn't suppress respiration so much. Uh, so the pharmacological characteristics or the effects that goes out of the mechanism of action. First of all, it is analgesic activity, especially in case of severe pain and traumas, myocardial infarction, tumors, shocks, severe inflammatory processes, and so on. Also, antitussive activity or anti-cough activity, as you can see, in case of pulmonary bleedings and persistent dry cough and so on. And stimulation of vagus nerves, stimulation of the oculomotor nerve of the eyes. And right now, I would like to draw your attention to the side effects of opioid analgesics, and actually the main reason why are they so restricted for their common use. Because this group of drugs, it causes dependence, and it causes any kind of dependence, as you can see, not only physical but also physiological dependence that may actually bring the person to their severe conditions such as abstinence, such as bradycardia, and such as inhibition of respiration. Here on slide you can see the features of the opioid analgesics. So when do we usually use different types of them? I told you that codeine are usually prescribed for the persistent strong dry cough, but not for a long period of time, while tramadol, for example, is a kind of the mechanism of action. It has both opioid and non-opioid activity, and it's widely used for traumas. And fentanyl is widely used for their analgesic activity during the surgical operations and after the surgical operations.
I'm sorry, we don't hear you very well.
And what about right now? Mm-hmm. Can you hear me now?
Yes, teacher, we can hear you.
Mm-hmm. That's great. So I shall continue. If something happens, please just tell me. And as you can see, that overdosing of the opioid analgesics brings to the lethal outcomes and due to their respiratory paralysis. And you should remember that antidote for opioid analgesics is naloxone or naltrexone, because these drugs are asked in your CROC testing. Also, you should remember that abrupt stoppage or abrupt withdrawal of the opioid analgesics brings the person to the abstinence, brings to the withdrawal syndrome, which is accompanied by fear, pain, anxiety, depression, and insomnia. And that's why we should remember that opioid analgesics must not be used it should be used very carefully because of this dependence and only in some severe cases. Right now, I would like to go to another part of our lecture, which is dedicated to the inflammation. And you can see that inflammation is also the universal response to the body, yeah? And somehow inflammation is actually, it's a result of many diseases. You can see that almost any disease has the step of inflammation inside. And you should remember that the process of inflammation, it could be different due to the different etiological factors, but finally there are 5 main symptoms of inflammation, and pain is among them. That is why we speak about it during today's lecture. You can see that there is an increase of the local temperature, which is called hyperemia. Yeah, it's like the first symptom of any inflammatory process. Along with edema, along with the pain, along with the reddening of the area and the disorders of function, we understand that we deal with inflammation. You can see that inflammation is a step, I have already said about it, is a step of any kind of disease. Of pneumonia, for example, it's also the inflammation of the lung tissue, yeah. And even though the right now we have the pneumonia, which is caused by the viruses, by the coronavirus, but still there is a step of their inflammation that brings the person to this huge cytokinic storm. And what is the structure of inflammatory reaction? There is a damage of the cell. It could be different damage. Yeah, it could be like, for example, viruses. It could be bacteria. It could be trauma. It could be high temperature or very low temperature. So any damage of the cell causes the phospholipids activation, which then brings the formation of arachidonic acid. And here, between the formation of arachidonic acid, there is a special enzyme that is called cyclooxygenase. I will call it later COX. And due to this enzyme, we have the release of very essential prostaglandins that actually helps us in some processes. They help us in some other processes. They increase the painful sensitivity, increase the permeability of the vessels, and as a result, they just bring our body to the inflammatory processes and to the pain. Here, I would like to show you where we can apply non-steroidal anti-inflammatory drugs. They are applied on this stage, yeah, on the stage of the cyclooxygenase 1 and 2 formation, where we can inhibit this enzymes, especially cyclooxygenase 2, which is responsible for the pain pathway. And as if we break it, then all these prostaglandins, which are responsible for the pain formation, won't be produced and the patient won't feel any pain. There is another way to kill the pain, and it also a very widely spread mechanism of action. It's just their killing of the phospholipase A2. And here we can apply, for example, glucocorticosteroids. So you should remember that glucocorticosteroids have a higher position, a higher step of the application, while non-steroidal anti-inflammatory drugs, they are used a little bit later. The characteristics of NSAIDs, you know that this group of drugs is so popular, and the popularity of this group is because of this wide application for any kind of inflammation process. And the second reason of this popularity is due to that fact that a lot of non-steroidal anti-inflammatory drugs, they belong to over-the-counter drugs, to the non-prescription drugs. According to the classification of NSAIDs, you can see that there are a lot of derivatives of different chemical compounds, yeah, of oxycane, salicylic, phenylpropionic. You will study all these subgroups during your pharmaceutical chemistry classes, during your pharmacology classes, and during your clinical pharmacology classes. But I would like to suggest you a little bit another classification which help you to understand their application, for example, of non-selective COX inhibitors. These are the drugs that are presented by different chemical compounds, but they act on two variants of cyclooxygenase, on the physiological cyclooxygenase, which is called COX-1, along with their pathological COX-2 enzyme that is responsible for pain and inflammation. While there are some special formed and newly developed drugs, such as selective COX-2 inhibitors, which act only on COX-2 and does not influence any COX-1 enzyme, and as a result they are more safe and they do not cause any gastrointestinal, for example, complications, and do not have any nephrotoxic activity. Here you can also find the selective, preferential selective COX-2 inhibitors, such as nimesulide, such as meloxicam, and some analgesic antipyretic drugs with poor anti-inflammatory effects. If we speak about the selective COX-2 inhibitors, drugs that only inhibit pathological COX-2 enzyme, there are two representatives. You can see that they have higher safety profile, meloxicam and nimesulide, and they do not cause any ulcerogenic effect, yeah, unlike non-selective NSAIDs. And you can see that they are really, really good drugs. But unfortunately, the selectivity, it's not a stable property of these drugs. And if we increase the dosage of selective COX-2 inhibitors, I mean of meloxicam and nimesulide, they will lose their selectivity and they will act like a usual non-selective NSAIDs. That's why I would like to present you the specific COX-2 inhibitors which do not lose their specific action on COX-2 enzyme, even if we increase their dosage in many times. And as you can see, they suppress the activity of enzyme, which is focused on inflammation. They possess anti-inflammatory, analgesic, and antipyretic activities, and they do not influence on the platelet aggregation. Here you can see some, for example, packages of these drugs. Celecoxib, it's an active compound, and Celebrex, it's a trade name of these drugs. Etarecoxib, it's also the specific COX-2 inhibitor, and its trade name is Arcoxia. You can see their indications like rheumatoid arthritis, like gout attacks, like osteoarthritis. And unfortunately, along with this positive profile and rather safe profile, they also have some very important contraindications, because unfortunately COX-2 inhibitors, they are contraindicated for the patients who have some problems with their heart and vessels. You can see the heart failure, the congestive heart failure also is a contraindication for this use. And the last minutes I would like to spend on the classification of just analgetics, antipyretics, which have this term AA, yeah? And among these drugs, there are some very famous drugs, such as paracetamol. You should remember that this compound, while having the small anti-inflammatory activity, still it belongs to the group that is called analgetics antipyretics, with small anti-inflammatory activity. You can see that it has a central component of action. It really acts on the COX-3 enzyme, which is formed in the central nervous system. And along with ketorolac, along with nefopam, also we have some medicines that have the peripheral pain-killing activity, such as sodium metamizole. It's a derivative of pyrazolone, or it has a second trade name like analgin. In your CROC testing, you will meet a lot of side effects about sodium metamizole, and its main side effect, which actually restricts its use, is negative action on the blood formation, on the blood counts. Also, you can see some spasmoanalgetics like spasmalgon, like, for example, paralgin. What are the pharmacodynamic effects or indications? If we speak about analgesic antipyretic, first of all, it should be fever. Yeah, in case of fever, we can use these drugs. And as a fever can be triggered by viral infections, by common cold, so we can apply these drugs in these indications. The effects, the main ones are the analgesic activity. In case of non-dangerous pain, when we have, for example, the extraction of the tooth, when we have the headache, when we have some pain in joints which are not very acute, muscular pain, etc. And actually, we are out of time. And if you have any questions, I would be happy to respond to these questions. Guys?
No. Yes, teacher, we have no questions.
I don't think so.
Okay, I hope that you will continue to study the names of the drugs and their classifications which are given to you in the pharmacology on pounds, please. It's really good opportunity to acquire new skills and to systemize your knowledge in this huge variety of the drugs, in this huge variety of the new names of the drugs. And as for today, I would like to say thank you for your attention. And actually, we have
thank you, teacher.
37 participants. I hope that you liked this lecture. And I'm looking forward to meeting with you next week. Bye-bye. It was my pleasure.
Bye-bye.
Goodbye, teacher.
Goodbye. Goodbye, everybody.
Bye-bye.
Bye, teacher.
Goodbye, teacher.
Goodbye.